Hi, everyone. Really excited to be here today with Danuta Lipinska to be here to talk to you guys about sexuality, dementia, and the well-being of individuals who are living with this disease. So I first want to take a moment to introduce our guest speaker today. She has worked with people with dementia in the community for over 30 years. She has a BA in psychology and an MA in counseling, both from the University of New Hampshire in the USA. She currently has worked, previously has worked as Director of Elderly Services in a community counseling service, a training consultant in dementia care and aging, and a qualified nurse, Director of Nursing in a residential care home. She is a registered and accredited member of the British Association of Counseling and Psychotherapy and the UKRC Association of Independent Practitioners. Danuta has designed and has run specialist counseling services for people with dementia and their carriers, and continues to support them as a counselor and supervisor of others. She is a freelance trainer, consultant, and international speaker. She is joining us from England today, so I appreciate you being here at this time with us. And so she's the speaker as well for their carers and continues to support them, as a counselor and supervisor of others. So she has recently been a tutor on the postgraduate diploma of in-person centered counseling at the Norwich Center for Counseling and Spiritual Accompaniment in Norwich, England, and that's where she is now. So before she gets started, I just have a few housekeeping to let you all know that we have in our handout section a few handouts for you all that will kind of cover some of the tips that Danuta will be speaking about, as well as a PDF of a sexual expression policy we'll touch base on. And as we go through this presentation, if any of you have questions, please type them in. And so that way, when we get to the Q&A section of this, we will have your questions there ready to go as you have them. So Danuta, without further ado, I'm going to let you get started. I'm going to hop off here and then I'll join you back on.
Thank you so much for that lovely introduction, Cara. And hi everyone, hello everyone from England. I'm delighted to be sharing this webinar with you today, Gay Pride Month in the UK and in the USA. And thank you, Cara and the Alzheimer's Federation of America for inviting me. And Cara and I have had some terrific conversations over the past few months, and I can't believe that we're finally here in the Zoom room, or the equivalent, with you all here today. So thank you all so much for coming along. So I'm going to be reading my presentation, but we'll have plenty of time afterwards to engage in, hopefully, in conversation and answering questions, hopefully, that you might have as we go through. So as Cara said, I've been working in the field of dementia training and support for many years now. And I first began as a nurse about 150 years ago, and then as a psychologist and a psychotherapist. I'm also the daughter of two delightful men stepdaughter, I should say, sorry, who developed dementia. One was vascular dementia and one was dementia with Lewy bodies. And sadly, both of those lovely men have passed, as has my mother. But I really learned up close and personal then about the challenges and the grief that she experienced as the caregiver and wife, and also of being a daughter and a professional in the field, 3,000 miles away and feeling helpless in the face of so much. But we're here today to explore sexuality and well-being for those who want to enjoy their sexuality and sensuality, love and romance, for as long as they are interested and able. But we're only going to be able to touch the tip of the iceberg today. So much more lies beneath what we introduce. Early in the 1980s in New Hampshire, I was invited to teach a course to postgraduate nurses on sexuality and healthy aging. We had a very interesting time and began exploring our own ageist attitudes. And this was the beginning of courses on this topic that I have been teaching and refining ever since that time. I also worked in a large community mental health organization as Elder Services Director, counseling women and men over the age of 60 across a broad spectrum of mental health challenges, including living with a diagnosis of a dementia or mild cognitive impairment. And then I returned to the UK in 1994, and I've continued that work here. So, sexually speaking, dementia, sex, and well-being, often considered the last taboo in living with dementia, Sex, dementia, and well-being are rarely discussed and hardly ever in the same sentence. I've spent many years in the company of women and men living with a dementia, their partners, and the professionals who support them as a counselor, a supervisor, and a training consultant. My book of the same title, published in 2018, was written to give voice to the concerns and experiences of these people who were emphatic that this book had to be written and that these conversations needed to happen. Clients let me know that this is an important area and one that is rarely addressed unless it's a problem to be solved, a behavior that is inappropriate, or something that must be stopped. I feel deeply that for older people and those living with a dementia, we need to have a way to have conversations that are fundamental to many adult relationships and experiences over many years. I think I also partly wrote the book for myself, and that as I age, and if I develop a dementia, I hope that people will see the whole of me, including my sexuality. I think that it's also important to point out that sex in later life isn't for everyone. And in spite of all of our 21st century openness and media frenzy around sex, it isn't all it's cracked up to be for everyone, even those in their younger years either. Some of us would just be as happy with a cuddle on the couch, a bowl of popcorn, and a box set on the TV. Thank you very much. In our time together today, I would like to highlight why this topic is not only important, but essential, the benefits of sexuality to well-being, adult sexuality and the impact of dementia on the brain, sex, and well-being. And we also want to ensure that we are supporting the human rights of the individual and that we concern ourselves with capacity and consent, equality, diversity, and inclusion as the foundations of best practice and the opportunity for living well with a dementia. In training sessions, I ask, when and under what circumstances can someone else decide that you can no longer have sex? Just think about that. Hundreds of people and over 2 continents and many, many years say no one and never, apart perhaps from criminal behavior. Yet without even thinking and at our peril, we tend to ignore sexuality in the lives of older people and those living with a dementia and their partners. Not out of malice, but out of fear perhaps, or lack of information and embarrassment at not having many opportunities to practice such conversations. We go on to make decisions about their sexual and intimate lives, present and future, without their consent and often without our own awareness. In the West, we're socialized to believe that we mostly do not talk to our elders, parents, or great-grandparents about sex, theirs or ours. Interestingly, current research tells us that sexual partners generally rarely talk to one another about their sex lives and preferences. In many cultures, the incest taboo exists to keep children and minors safe from sexual abuse and exploitation within families and communities. This is partly why it is so difficult to imagine our elders and parents and grandparents and even great-grandparents as separate sexual adults, especially when they develop a dementia and the roles tend to be reversed. It isn't easy to have these conversations or even to entertain them in our heads. Trained and sensitive health and social care staff can and do make a difference in acting as advocates for older adults and those with dementia and their rights to live as fully as they are safe and able to do so. It is also highly likely that fear of stigma and being thought foolish or past it prevents older adults, whether single or in relationships, to talk about their sexual concerns. This is even more so when people are living with dementia. It is as if this part of them has also been switched off, sometimes by them and often by others, by us. Physical difficulties that for some accompany aging can be helped if only someone would listen and someone would offer. Age-related changes in libido, erection and lubrication, and arthritis contributing to positioning challenges, to name just a few. The dictionary defines well-being as a state of being comfortable, healthy, or happy. What then is being person-centered? It basically means that the focus of our attention or concern is the individual, the person living with a dementia, their partners and family. But let's look a bit more closely at sex from that perspective of being person-centered and of well-being. We are sexual creatures in the womb. We stop being sexual creatures when we stop breathing. What we do with that sexuality and how we express and experience it or not is another story for another day. Sex is one of the biological imperatives or must-haves in order to survive. That doesn't mean that you must have sex this instant or you will die, although many teenagers truly believe this, but the species will. The other biological imperatives, just to remind us, are eating, sleeping, eliminating waste, and drinking. This collection shows us just how important sex is and is hardwired into the human organism to make sure that we continue to exist. We are also extraordinary creatures when it comes to the whole range of human sexualities, including lesbian, gay, bisexual, transgender, queer, plus, straight, and of course as many possibilities as there are humans. Being fluid in sexuality without a label to identify with is also appropriate, as is being celibate and asexual, to name but a few variations. How do we approach men and women whose sexuality may have been a secret from family and friends, and maybe even partners, those who have memories of abuse and imprisonment? How do we support those newly diagnosed with a dementia who are happily single, LGBTQ+ and straight, and have no desire to be part of a couple or a traditional relationship? Those who have lost partners to death and divorce. This will involve having a conversation and demonstrating our authentic willingness to listen, to learn, to appreciate, to imagine, and to co-create how a person may continue to enjoy their sex life for as long as they desire and in ways that are safe, satisfying, and legal. As for all adults and sex, it must, by law, be consensual. When we step across the threshold into community services and residential living, where other people are now looking into our private lives, the law becomes essential to promote safety and dignity and to ensure that vulnerable adults are not put at risk. There's a fine line between upholding rights and measuring risk in sexual behavior. However, each individual situation must be taken into account and the rights of the individual upheld and the vulnerable safeguarded. The ability of the individual to exercise capacity to consent to sex is a situation-specific and time-limited legal status which must be sensitively sought and applied, and where necessary, reviewed. I learned a great deal about older people and sexuality and dementia from counseling clients who are partners or people living with dementia. In the early sessions, usually by session 2, and without any questions or prompting from me, clients usually would begin to tell me about their sex lives, the pleasure, regrets, painful pasts, concerns, and hopes for the future, and I started to pay close attention. There was a fair amount of trauma, but there was also joy and passion and delight and considerable well-being. I acknowledge that there can be great harm, trauma, and distress caused by sexual abuse and ignorance, stereotyping, fear, and prejudice that can be associated with sexuality in later life. And we do talk about the influence of these experiences on clients and residents living with a dementia. But I've rarely heard the conversation that looks at distressed behaviors as possible sexual frustration or grief over the loss of this intimate and important aspect of identity, pleasure, and well-being. The usual expression or way of talking about it could be inappropriate sexual behavior, and it is more likely to be the context the timing, the people and the place that render what is usually private and consensual adult sexual experience as inappropriate because it isn't very private any longer. So here is an invitation to affirm our current good practice or attitudes and to challenge whatever doesn't fit in the best interest of the person's well-being and human rights, including safeguarding that person's right to be free from abuse or exploitation. Through my extensive experience of nearly 40 years and over 2 continents, I became aware of the challenges and difficulties associated with adult sexuality, relationships and intimacy when a person was living with a dementia. But I wanted to flip that coin and to look at the benefits of human sexuality irrespective of age, gender, sexual preferences, diagnosis or living environment. Here's an example from the book. Phil was referred for counselling for depression following his recent stroke and increasing memory loss. At the second session, he told me, "It's about the sex. That's why I'm depressed." Or actually what turned out to be lack of sex. Phil went on to say that he knew his depression was partly due to not being able to have sex with his wife of 58 years. According to him, she shut up shop during the menopause, and he had been suffering ever since. He didn't want to come to the end of his life without having sex with her again. In counselling, we explored ways for Phil to court Marilyn again, and it began with simple things like sitting together on the sofa instead of armchairs to watch the television, putting his arms around her from behind when she was at the sink or the stove and nuzzling her neck. Marilyn was very appreciative of the new Phil. Several weeks after the homework, he arrived with 2 thumbs up. "Twice," he said, and it had been wonderful for them both. He described how important it had been for him to talk about this private but essential part of his life. A couple of weeks later, Phil didn't arrive for his scheduled appointment with me. This was most unusual. I learned later from his social worker that he had died sitting peacefully on his deck at home. I like to imagine that there was a smile on his face. Phil is only one example, but I share this as an encouragement that no matter the diagnosis, appearance and expectations concerning aging, dementia and sex, there may well be other things going on beneath the surface. We also know that 1 in 20 people develop young onset dementia before the age of 60, and these women and men also have sexual histories, a present and a future. But most websites supporting people with dementia assume that those interested in sex are part of a heterosexual relationship or partnership or husband and wife. But 21st century living with dementia tells us otherwise, and we must inform our understanding and develop our sensitivity. I'm going to have a sip of water now. Now, a bit about the brain. We are told that the brain is the biggest sex organ. So let's take a few minutes to talk about what happens to the brain and sex and dementia. We've already seen that sex is hardwired into species survival as one of the biological imperatives, but we learn how to switch off desires, thoughts and feelings which keep us culturally and socially safe. That means that we learn to delay gratification until the situation, person, time or place is appropriate for sex. We have learned how to deflect, deny, postpone and delay these feelings and desires over the course of our adult lifetimes. And the key word here is learn. And what has been learned can be forgotten when living with the memory changes accompanying a dementia. But we are in error if we place all responsibility for memory only in the brain. But that is easy to do since it's the primary organ which the hallmark characteristics of cognitive change are found. We are embodied beings, which means that our brain does not function in isolation from the rest of the whole of our being, and our body and muscle and sensory and spiritual memories interact with neurology and with the world around us. Angela told me that although her husband Peter didn't necessarily remember her name or who she was every day, they continued to enjoy their sexual relationship. Angela felt that during those times of intimacy, Peter really did know her and cherish her, and they were able to communicate through their sensual and sexual expression that had been remembered in his body, emotional and spiritual memory, even when her name, or that she was his wife of 40 years, did not. She said, "This connection we have makes it easier for me to get up again the next day and carry on the caregiving role. It is an essential part of our communication." We also know that the brain, weighing in at a little over 3 pounds and looking and feeling like a bowl of yesterday's cold oatmeal, is the control center of all that is going on. But it is not alone in its efforts to make up the complete person, as I have already mentioned. It controls all aspects of our chemical, hormonal, psychological, physical, emotional, and spiritual selves. Although the brain needs to be fairly functional to engage with sex, alone or with another, it doesn't have to function perfectly. There is a powerful cocktail of brain chemistry involved in our sexuality. Much of this can be changed as a result of conditions that cause dementia, but it doesn't all happen at once, but over time and in unpredictable patterns of being present and absence, and depending on hundreds of other interactions happening at the same time. The limbic system, deeply folded into the center of the brain, our evolutionary emotional system responsible for the fight and flight response, among others, also steers us away from painful events and towards the pleasurable ones, including sex. So is it any wonder that when life doesn't hold too many fun and pleasurable experiences, our thoughts and feelings may turn to sex? We naturally seek out what feels good, and our brain is primed to do so. Sex in general and masturbation or self-pleasuring is usually free and an easily available form of stress relief, relaxation, pleasure, sleep enhancement, and a connection with self that still gives autonomy and agency to the person when other aspects of control over one's body and privacy may have become diminished. It is also an antidote to boredom, and for some, part of their activities of daily living. We learn and are socialized to take our minds and bodies off sex, and sometimes also find a way to release pent-up energy through physical activity that brings pleasure and a release of energy, resulting in feelings of relaxation and well-being. Clearly not ever as good as an orgasm, but a reasonable distraction. But as dementia progresses, for some people there is less awareness of what constitutes private information or behavior, and we describe this language or behavior as becoming disinhibited. This is a lowering of sexual and social defenses, which the front part of the brain, the frontal cortex, controls. As a result of dementia or trauma, extreme pain, tumor, or medication, a person can become disinhibited. Socially, we can choose to lose our inhibitions through drugs and alcohol, which makes us behave in socially and/or sexually more relaxed ways. The uninhibited person and their sexuality may emerge, including those who may have lived a private life that didn't bear any resemblance to the one that they lived in public view. This could mean that a person behaves sexually from a lesbian, gay, bisexual, or transsexual authentic self that has previously been hidden. It may also lead back in long-term memory to incidents of abuse as victim or perpetrator, or to other partners and affairs outside of the recognized partnership. Men and women can become equally disinhibited and their innermost sexual longings and behavior set free. These deep-seated and fundamental sexual behaviors will also remain when a cultural, social, or religious role concerning sexuality has been forgotten. And so we can imagine the complexity of interplay between the many elements of sexual desire, the need for intimacy and comfort in our first assessment. And the first assessment, actually, behavior that appears to be sexually motivated may in fact be something else, but equally necessary for well-being. Let me briefly introduce Gary and Joe as an example. Gary, a retired teacher, is a resident at Briarwood Nursing Home. His husband, Joe, is a regular visitor. When he comes to visit, the administrator tells him that Gary has been found naked in the beds of other residents, both men and women. After much discussion, it came to light that Gary was seeking comfort and companionship. He and Joe had slept together naked for 25 years with a selection of cats, dogs, cushions, and furry blankets. Barney, their Yorkshire Terrier, was brought in for naps and cuddles with Gary, as well as a selection of cushions and throws and Joe's favourite dressing gown. Gary's quest for bed buddies ended, and Barney continues to visit at nap time. In the grand scheme of things, and throughout discussions over the years, what is very clear to me is that most of us agree that it would be beneficial to have conversations about sex, sex and dementia, sex and aging, sex and well-being. But I have never been told how to have these necessary but possibly tricky conversations, and most people tell me that they haven't either. So what I propose is a new model. Sexually speaking, a person-centered approach to tricky conversations. I hope to encourage us to bring our thinking and practice into the 21st century. We cannot claim to be working in holistic, person-centered ways if we leave these important conversations unspoken and do not venture below the belt, so to speak. But not everyone will have these conversations in their career or in their family, but we must have them with ourselves, our partners, and within our staff teams so that we have a better understanding and appreciation of the whole person. Yes, this is a private and sensitive area of a person's life. But so are finances, bowel movements, religion, end-of-life care, and funeral plans. And yet somehow we manage to have these conversations. Training in sexuality and intimacy and relationships is also essential to maintain safe and effective practice and to support and equip partners and family caregivers. Having open conversations as partners, family, staff members, and advocates for adults living with a dementia is essential so that we can avoid the possibility of what is natural human behavior being misinterpreted, made foolish, wrong, or dirty, or even criminalized. Person-centered conversations begin with the work of Carl Rogers, who created the person-centered approach in counseling relationships. And these have been adopted by organizations worldwide as a means of creating helpful or therapeutic relationships. We can be helpful in this process if we are ACE. A, accepting and not judgmental or visibly shocked. C, congruent, being authentic, genuine, consistent, being who we say we are, and having a reliable, consistent attitude and approach. And E, empathic, showing a genuine concern and wanting to see things from the other person's viewpoint, putting ourselves in their shoes. And this ACE approach can be our own preparation for having these conversations. Tom Kitwood revolutionized caring for those living with a dementia when in 1997, he introduced us to the person-centered approach based on Carl Rogers. Thank you, Cara. I was going to ask you to put the slide up for us. He gave us this visual image of a flower with each petal representing a psychological need of a person living with a dementia. We can use the flower as a template around which to build our conversations and how we might write our care plans to include sexuality, sensuality, intimacy across sexualities. Here we have an objective way to address these aspects of daily living, steering clear of our own opinions and views, and truly advocating for the adult we support. These 5 needs are comfort, inclusion, identity, attachment, and occupation. Let's look at each briefly when thinking about sexually speaking. Comfort. How can I help this person to feel comfortable now? How comfortable can I be having this conversation? How do I share this with the other person, this ability to be comfortable? Inclusion. How do we have this conversation together? How can I include this person in what we talk about? How, where, and with whom do they want to have this conversation? Identity. Who is this person and how do they describe themselves? How do they identify sexually? Is that important to them? Attachment. Who are they attached to? Who are their partners, spouses, lovers, children, pets, friends, and colleagues? Where do they find meaningful connections? And occupation. What is meaningful to them in their lives regarding their sexuality and sensuality? How do they want to continue, if they do, to experience and express their sexual, sensual selves, to spend their time in meaningful engagement, including sexual engagement? And actually, when I look at these on the screen here, these are what I need in my life too. At the center of the flower is the word love, for which I'm guessing that there are as many interpretations as there are people. We know that people can experience sex with and without love, and it isn't helpful to assume that love is always, or ought to be, present. There may be many ways of feeling positive towards a person, but the individual may not describe this as love. We will wait to hear how they speak about it and be guided by their experience of it. These areas of life-affirming importance to us as humans can be brought into the realm of person-centered approaches and ways of considering how living with a dementia affects sexual identity and expression, and how this contributes to well-being. I'd like to end with a couple of lines from a song from the film Casablanca. I'm not going to sing it, so it's okay. You must remember this. A kiss is still a kiss. A sigh is just a sigh. The fundamental things in life apply as time goes by. Thank you very much for listening. Over to you, Cara.
Yes, I'm happy to be back here and thank you for speaking with us. So now this is the time where if anyone has questions to type them in. Myself and Danuta are here to talk about the things that have come up. So I do have someone who's asked us, because I started making some lists when people were asking. And the first question they actually asked is, can you have a mother go through menopause and have dementia at the same time?
Well, if we agree that people develop a young onset dementia under the age of 60, then that is certainly a possibility. Without being too personal, I, for one, went through an early menopause triggered by a minor head injury at 48. So I could go on to develop a dementia, and that head injury would be a risk factor for me. But I did actually go through menopause, so I would think that's absolutely possible.
Exactly. And it's just being mindful of that also, because that can happen at different stages of age for each person. And some people kind of early onset or later onset, it's something to consider. I have someone else who asked, how can you maintain intimacy with your partner? So that, I think they were trying to say that their person might have had the diagnosis. So how can they maintain intimacy?
Yeah. Well, that's the $64 million question. It's a great one. Thank you. And I guess I always start with, well, what's been working?
Mhm.
We tend to become quite focused on the diagnosis, and obviously for many, many reasons, why wouldn't we? But actually that person that you have been intimate with for however long is still that person. And even though they might not remember how, how to make the bagels in the morning, they may well, as I highlighted Angela and Peter's situation, you may
Yeah.
well be able to relate really well, intimately together for a long, long time. So I think it's really about being yourself and inviting that other person to be who you know them to be, even if they may not remember themselves, but to continue to gently, involve one another in your intimate life, and just to see what happens and not be too sort of tied to any of it if it doesn't feel like it's right or it doesn't go well that next time, to hold things lightly and be willing to experiment and to move on to something different. I don't know if that answers the question,
No, I
Cara.
think definitely. It actually, this question that the person asked reminds me of a person that on the helpline who I've talked to has called, where she actually asked the facility if they could put in a bigger bed in her husband's room. He was moving into memory care. She asked for a bigger bed because he might not know my name at times. He might not remember what I look like, but when I lay down next to him in bed and just make that eye contact, he knows who I am.
Oh my goodness, and you hadn't even heard about Angela and Peter.
Exactly. And then I was like, when you say the story, I was like, yes. So then I was like, okay.
Yes, yeah. And when you think of how complex we all are, there are very many levels at which we know each other and are known, whether that's around sexuality or not. So we're sort of employing all of those senses, aren't we, when someone has a diagnosis, to keep us connected and keep that relationship vibrant as much as we can.
Yes, yes. And then I do had someone who asked, what do you do when your person seems to become obsessed with pornography when later on in their diagnosis, maybe from hypersexuality and so on?
With pornography, did you say?
Yes. So we actually had a
Uh-huh.
client who became obsessed with it past diagnosis, which there's no issues with it, or not. But this was a question that came up.
Yeah. Well, we know that there are lots of different things that trigger feelings of sexuality and sexual interest and lust and all of that stuff. And as we said before, if there isn't an awful lot of other stuff going on in your life and you may not feel you've got much control over other things, if this is something that makes you feel good, that makes you feel autonomous, that makes you feel independent, that makes you feel desired or desirable, it's going to be difficult to shut that down. So as long as it's not harming anyone else or encroaching on anyone else's rights not to have pornography in their face, then we have to really support the individual and their right to have privacy around, their viewing and reading material and sex toys and all of those sorts of other things that adults find useful and stimulating. And as I said, in the presentation, Cara, it's only because someone else has got their eyeballs on your life now
Yeah.
that the things that were private are now out in the public domain. And so it makes it, really tricky. But we can do things to ensure that people can still have their privacy. And, one person's obsession may not be the same as how someone else would describe it. I only, only look at two magazines. What? You look at two magazines? So question of interpretation, but always bearing in mind keeping somebody safe and free from being vulnerable around others, free from embarrassment and humiliation for themselves as well as for anyone else in the vicinity.
And I think it's like you said, we want to try and remove that negative connotation when someone might be expressing themselves in this manner, and really put our curiosity into what's engaging them, for them, what is important for them, what purpose is this serving for them, because there could be a very big meaningful purpose there for them, and that's why they're expressing in this regard. So I have another person who asked, if the person with dementia is displaying signs of a sexual need, how can that be recognized as a real need, and not just be dismissed by someone because they have dementia. Does that make sense?
Yeah, and I think the crux of the issue is what we've been talking about, Cara, isn't it? That it's part of who we all are as human beings, whether we have cognitive changes or not due to dementia or mental health conditions or anything else. That, by nature we are sexual beings and it's part of who we are. But as we're socialized and enculturated, we learn to hide so much of that aspect of ourselves. And so, in situations where we might be less inhibited, those sexual needs may become much more apparent, even though it might be, your or my desire not to have them visualized or heard by others, but we may not be able to control that. But it's essentially who part of our human nature. So it's going back to the bigger question is, who is the whole person? And prior to diagnosis, most people would have been sexually active, not everyone for sure, but that gives us some information in terms of, so what's happening to that now? Where has all of that gone now? And it's not like a light switch, that we just flip off and on. It's part of our being, isn't it?
It is, and everyone has different, life experiences, and so we and caveat that too. Everyone has different sexual experiences in their life, so it's really going to pertain to that individual and their own relationship with themselves and their own comfortability. I do have someone who has asked us, how do we deal with consent when one person in the relationship can't recognize the other person and kind of play that role, I guess.
Yeah, and that's such a hard thing, isn't it? To have been with someone in relationship and they don't recognize us. It's very, very hard, and also tricky when your son is a spitting image of your husband when you met him. And misunderstanding who people are, and adult children and grandchildren just feeling absolutely ghastly, when someone's making sexual overtures to them. So really, really difficult, and I've totally lost the beginning of the question, Cara.
That's totally fine. So is talking about, how does a person give consent? And I think this is a bigger, broader question that comes up, in many places, not just, I'd say worldly, how does a person with this disease give consent with their partner when they have this diagnosis?
Yeah, and that's a really difficult one. Wouldn't it be great if we could just say, whatever you want to do is okay, but we know that sex has to be consensual between all those involved. And so it may be that there need to be different ways of connecting with each other that are that feel really, really good and healthy and important. But it may be that the way you used to connect may not be the same thing anymore. But having said that, there are lots of different things that people can try, and that someone will say very easily, yes, I like this, I want to do this. But as we said earlier, it's because there are other people who are looking into your life and your relationship and have the ability to make comments. But within a relationship, we always want to make sure that we're both wanting the same thing. And what's interesting is, that when you've been with somebody for 40 years, you don't usually say, are we going to have sex tonight? Do you consent? Do you have capacity to tell me right now? And it could be that you've had a hard day, that you're not really feeling very sexual, but because you know each other so well, you find that in the end, you're making love and you didn't, realize it. And that's not the same thing as being coerced. But so, it's a very, very individual experience. And being willing to be open to different ways of expressing intimacy and sexuality and sensuality, maybe not the same as you used to know, but that idea of how and under what circumstances will this person recognize me? Maybe it's their favorite meal that you make, maybe it's your perfume, maybe it's the touch of your hand in a certain spot on their neck that makes the difference. But you know, we all know what that is, but we never imagined we'd have to pay such close attention.
Yeah, you talked about Danuta, where it's when you have this disease, right, you lose that control to kind of keep those things private, your experiences, your, desires, all those things. And then when unfortunately you get this diagnosis, that's where some of this stuff can pop up, where people have never, heard their person express this before, because they don't have that capability to, self-disclose or not to self-disclose.
Yes, and those boundaries become very, very open, don't they? That we used to keep ourselves socially and sexually safe, culturally safe. But the more we know about the possibilities of what can happen, the less shocked we're going to be, the more able we're going to be to say, okay, here we are. So what are we going to do? How are we going to feel about this? What are we going to do to stay well connected and stay safe, and not be, not be judgmental and not be shocked? But it's very difficult when you've known someone for a long time, or when that person is your elder, within your family or your community. Very, very hard, very hard.
Yeah.
None of this necessarily a walk in the park, for sure. But if we shut it all down, Cara, my concern is then that we don't enjoy the possibility of well-being for as long as we can, because it is, part of that whole human experience that when it goes well, sexuality and sensuality, romance, and if you want to chuck some love in there as well, really does encourage well-being. And we know that well-being has such a positive effect, not just on the body, but on the brain. So if the brain is the organ that's struggling, let's give it some goodies.
And a lot of times it's really the power of touch, of that closeness people feel with each other. And especially, like we said, if people have been with their partner for so many plus years, it can be very muscle memory to just go and be with them. I do have someone who asked a question, saying her team, they work at an adult day center. They've had concerns in the past where a married man who has dementia, and then there was a single woman with dementia, they were both at the program, and when they were paired up, they might fondle each other while being in public. And this was hard for the man's wife, because when he would go home in the evening, it was upsetting. And that brings up a lot of feelings. So I think we first need to realize, there's definitely different roles that are ongoing here. We also need to know that, because in this question she's saying it's being done, in public, that just because it's being done in public doesn't mean that awareness is there for that person. With society, there is kind of that ingrained, don't do this in public, do this in private. This is good behavior, this is bad behavior. Those filters are gone when you have this disease. So we really need to kind of come into it with that play. But I would love to hear what you think, Danuta, about kind of this case example that she provided us with.
So thank you for that. And of course, my initial thought is for the privacy and safety of the couple involved, and also that the other people, anyone in the vicinity, that they're not feeling embarrassed, and vulnerable themselves. So getting the couple to a private situation would probably be my first thought. And sometimes by the time you reroute people to that other situation, they're not interested in doing what they were doing, before. But that's not always the case. So we need to assume that they need to have privacy. So that making sure people are safe and that it's private and that people are not going to be vulnerable to other abuse or embarrassment. But then is the bigger question then. So if these people are married to others, there need to be conversations about, so this is what we know about what happens to brain and behavior when people experience living with a dementia. How do we work together to support your relative, your family member, your wife, and recognizing them as an independent adult under the Human Rights Act with rights and needs, but also ensuring that we support you as their partner, their husband, wife, whatever, and have conversations that are going to be helpful and useful in terms of what do you want us to do as care staff if something like this happens. This is a natural human feeling, and if there's someone right there, it's that person isn't filtering whether they're their person or someone else. It's not making sense, as you said, Cara. So how do we work together rather than things getting to a point where an issue or a so-called, a problem seems to be on the cards?
I would say eviction sometimes.
Yes.
Mm-hmm.
Yes, we need to look holistically and be really sensitive to what the two people need, but also thinking more broadly about how are we going to respond in ways that are supportive, but also that safeguard individuals and try and pay attention to relationships that already exist. And I don't know, each situation is going to be different. So I wouldn't want to suggest a blanket, one answer for everything. That's for sure.
And I think it's helpful that you're kind of explaining, the thought process of, these are things we want to think about, because just like you said, every situation is going to be different. And, as we are talking, worldly here, because we do have people who are on here in different places in the world, it's different in different places. And this actually brings us to consent and how that's looked at different facilities, different states, different countries, and so on. And just to let you all know, in the handout section, there is an example from one of the facilities that is in New York, the sexual expression policy. Now, that does not mean that's for every single place, because one of the questions I'm seeing is, how does coercion play into this role of consent? And that's where that really does can go to the legal side, and that depends on people's policies, depends on state policies, federal, and so on. So I just wanted to insert that part there, since I saw that question come up about facilities.
Helpful. Thank you. Yes.
And so I do have another question, and this person's question is, my father thinks that I'm his wife, and sometimes at night he asks me to come cuddle with him. What do I say?
I'm guessing that the person who's asked the question has probably got some fantastic ways of responding to the situation in the moment already. So when it's something like that, it's acknowledging, you must really miss mom or whatever, and reaffirming, I'm your daughter, and of course I'd give you a cuddle, but I'm cuddling you. You're my dad, and whatever went on between you and mom, that was your thing. But the person is obviously wanting and needing and missing the connection, the intimacy, possibly the sex. And we just have to be really clear about keeping those boundaries to keep ourselves and that other person safe. And I know, and I mentioned in my presentation, that unfortunately there are situations that really do become very difficult and bordering on being criminal. But and we want to acknowledge that, and for people to make sure that they stay safe. But the focus of the book was really looking at the other side of, looking at the well-being piece of it. So I imagine that woman's dad would really appreciate a cuddle from his daughter, if that's really clearly delineated, and then, thinking about, okay, so who can he talk to in terms of, missing the intimacy and the sexuality? And it may not be, the adult child's position to do that. It may be that it's someone else that can do that a lot better, in standing in that advocacy role and being able to balance the rights and risks around the Human Rights Act and the individual's right to, expression, but also supporting the person who may be feeling really left behind.
Exactly. And it goes back to your point about really just we don't want to make him feel ashamed that he thinks that this is his wife because she's reminding him of another time of his life. So, ultimately, we really want to try and go with that nonchalant kind of tone and very person-centered approach, and, being able to address the person in that manner so they don't feel embarrassed that this has kind of come up.
Yeah, and the other thing that I just want to add there, Cara, if I may, is that it's sort of a backhanded compliment in a way, That when people feel safe, when they feel that they're being heard and listened to, they feel more able to interact in affectionate ways.
Yeah.
And unfortunately, sometimes that goes beyond affection into more intimacy and sexuality. But if that person was afraid, if they felt intimidated, if they felt unsafe, then that inner aspect of self that engages with others through sensuality and sexuality, that would be hidden well away, because you wouldn't dare want to expose yourself, literally and metaphorically probably. And so when we're working in really good person-centered ways, then the individual and the person feels okay to be who they are, and that includes their need for intimacy and connection and sex, but not for everyone, as we've already said.
Yeah, there might be some people that this does not come up for. And so this is why sometimes, if you do have an early diagnosis, or even if you just have these conversations prior, this can help prevent, issues down the line, but you're also having that conversation early on with family, with friends, whoever's involved. So this way they kind of like have an idea. It's one of the conversations. And just like you said, Danuta, we talk about end of life care. We talk about finance. We talk about all these personal things. This is one of the things that we can also talk about. And then I'll go to the next question that I do have from someone who said, this one's a little more specific, but it's, how can I get my person to stop masturbating all the time? So it seems like this one, again, we really want to approach it without that negative connotation, and really look at that unmet need. So a lot of times when someone is exhibiting any behavior, not just sexual, there's usually a meaning behind it or a need behind it.
Yeah. And for many people, this is one of the great stress relievers. And when left to our own devices, human beings find ways to relieve stress. Sex, orgasm, masturbation, self-pleasuring are ways in which that happens. The fact that this is now living with a diagnosis of a dementia, possibly one of the most stressful things that you're going through, the likelihood is that if you've been used to self-pleasuring to reduce, either to reduce stress and anxiety, or to relieve boredom and give yourself something to do that's pleasurable, then the chances of the number of times that might be happening in any given 24-hour period, we could imagine that that's going to escalate. So the bigger picture then is, if we can't meet sexual need, how do we help this person feel less distressed, less anxious, less bored, less disenfranchised from community, from other people, from doing things that help to give an experience, as I had talked about, of releasing energy, even though it's not an orgasmic energy, it's releasing physical energy, sitting back and feeling positive feelings and relaxation that are approximate to post-coital or post-orgasmic experience, but that are not aligned with a sexual expression. So as we say, every person's different, but this is natural human behavior. Babies masturbate to orgasm. Lactating mothers, can orgasm when they're nursing their children. It's part of who we are. And we want to appreciate that. We're not going to be saying we're condoning that everybody ought to be having a sex life and self-pleasuring, but we want to really be aware that this is not unusual human behavior. But it may be that the context and the situation and whoever's involved and the environment is not what this person would want or be used to.
Exactly. And we just want to, put our hat on, and when something pops up, really go into it with an open mind and figure out what the situation is. Obviously, it's something, if it's bringing contentness and happiness, we do want to explore that, because, we're looking at the dignity and worth of every person. And that doesn't stop just because someone has a diagnosis. They can still live a happy and fulfilled life. Now, obviously, if this was something that became, abusive, that's another end of it where we would look into, something else and go down like legal ways for that. But today's focus was really talking about the positivities that can come from it. How can we make a person and feel comfortable, as well as, you know, what do we need to address as ourselves as professionals or family members to make ourselves comfortable to talk about it with them too.
Yes.
Well,
I hope we've done a little bit of that. I hope we've managed it, Cara.
I think we've had a lot of questions, and, you know, I do want to end with that. If any of you have questions, you know, further about what you're seeing, because I do still see some coming in. So I'm happy that this is a topic that is really resonating with many of you. You can certainly email me, and then I can be able to pass information along to Danuta about different things that come up. Obviously, there's so much in the realm of sexuality that we are not going to be able to touch on every single aspect within this time, but we are happy to just start this conversation about what's going on. And I appreciate you being here with us today, Danuta.
And I'm really thrilled that you've invited me and that we've got so many great questions and hopefully opening some doors to other conversations along the way. Thank you so much for having me.
No problem. And so just so everyone knows, I will be emailing out the general certificate along with the information Danuta provided us on our tips. So I will be sending that out shortly. And thank you everyone for joining us, and take care, Danuta. Thank you again for joining us from England.
Bye. Have a great summer, everyone.
Take care.